You're listening to the Animal Heartbeat. My name is Kieran Borget.
Hi, and I'm Jose and Kieran. This is the world's only podcast dedicated to veterinary cardiology.
Welcome, everybody, to a little different style of episode of the Animal Heartbeat this week. Hi, Jose. How are you?
Hi, Kieran. I'm good. How are you?
Yeah, good. So we're talking about how we could diversify what the Animal Heartbeat is doing, and we decided that we would each pick some scientific articles from 2025 and talk about our highlights and what was interesting for us. We've talked about this for a while, haven't we? The idea of doing this with published papers.
Yeah, indeed. It's an area that I think is very exciting to discuss some of the papers out there that we felt like are clinically relevant or that people have been talking about it. So like a bit like a journal club, I guess. Other podcasts are doing that.
Yeah. This is where my residents are laughing because they're like, he's there, but he never reads the paper. So I would like to thank all the residents that I work with for bringing these great articles to my attention at some point over the last few months and acting as a jumping off point for doing further reading. It's weird not having a guest, right? Back
to the origins, where everything started.
Back to the basics. Back to the basics. Our guest today is scientific research. That's the guest that we brought to the table, and let's interview that. So, in the spirit of that, what would you like to begin with? One of your highlights of the year?
Yeah, sure. Again, it's important to say that it's always very difficult to pick one paper or a couple of papers because there's so much stuff being published at the moment. So it's always difficult to pick one paper, one highlight. But a paper that I was very impressed with, and it's not about cats and it's not about cardiomyopathies, which might be a bit shocking, but exactly, is a paper published by Dr. Masami Ueki from Japan group at JVIM on the preoperative prediction models for 30-day all-cause mortality after mitral valve repair in dogs. This is a very impressive paper, very, very impressive manuscript. As everyone will know, Dr. Ueki group has pioneered mitral valve repair in veterinary cardiology in dogs. I guess their first paper was published in 2012, and since then they have been doing this surgery a bit all over the world and publishing it. What I think is very impressive is they are clearly outstanding clinicians and surgeons, and they still find the time to publish their data, which is certainly quite unique to be able to be so active in the clinic and still be able to put together and publish their data, which I think it's really outstanding. So in this paper, what they tried to do was to develop a predictive model for 30-day post-op mortality in dogs undergoing mitral valve repair. So these kind of models are common in humans undergoing cardiac surgery, and there are many publications in people assessing 30-day mortality and to try to predict 30-day mortality, which is something we don't have really much in the veterinary literature. So I think, first of all, it's really
an interesting idea, though, isn't it?
Yeah, it's one of the very few papers, I think, if not the only paper, trying to assess that certainly in cardiac surgery and in dogs undergoing a surgery procedure. Really impressive numbers from his group. 70% of dogs with mitral valve disease stage C undergoing mitral valve repair in their group has a survival rate over 36 months. So these are dogs in stage C, and in their medical treatment has shown mean survival times of 8-9 months. 70% of their dogs survives over 36 months. It's very impressive.
These are old dogs, aren't they? These are geriatric dogs. So they have comorbidities.
Exactly. For example, the mean age here, the median age was 10 years,
right,
ranging between 9 and 12. So yeah, exactly. It's quite very, very impressive. And so what they want to do was that they wanted to develop a model that would predict mortality. And only the idea is, of course, is very neat. So if you have a patient that might undergo, or the clients, the owners, the carers are considering undergoing mitral valve repair, the clinician could use this model to predict what's the probability of this patient to survive. The study is very carefully designed. They have used advanced statistical methods, and is very, very carefully done and carefully written. They followed human guidelines called the transparent reporting of a multivariable prediction model for individual prognosis or diagnosis. So they've written these according to human guidelines on how to report, how to develop, how to design these models. So is a very well done study. So these were cases recruited in Ueki's center, Jasmine Veterinary Cardiovascular Medical Center in Japan between 2016 and 2023. Two surgeons, they only had two surgeons doing mitral valve repair in these dogs. And again, their idea was to look at predictive variables, at variables that could predict mortality. And these were all pre-op variables. So all variables like signal element variables such as sex, breed, body weight, blood tests, diagnostic imaging, mainly echo and VHS, and pre-op medication. So there's a large number of variables, and they looked at these variables could predict a 30-day mortality. What they also did, because one could say, well, is it 30-day mortality really a useful cutoff or a useful predictor? But they use 30-day because that's the classic time frame used in human cardiac surgery. But then they also use the model to predict the 2-year survival. So they look at which model predicted 30-day cardiac mortality, but then they checked if that same model could predict all-cause death over 2 years.
I think the 30 days sort of seems reasonable, because if you did survival to discharge from hospital, which feels like perioperative mortality, and in lots of studies they talk about survival to discharge, that doesn't capture the dogs who maybe one of their artificial chordae pulls through the valve or something and they get pulmonary edema 2 weeks later. So I think 30 days is it's arbitrary but sensible.
Yeah, I agree exactly. And that, I think if we think of the most common complications with heart surgery and mitral valve repair, like stuff like endocarditis and so on, I think if things go wrong, will go wrong in the first 4 weeks. So I think it makes, I agree, is a reasonable cutoff. And so, they did multivariable binary logistic regression, and the primary outcome was this 30-day mortality. And what they did, and then the stats are rather complex, but what they did, they create 5 different predictive models. One model where they included all predictive variables, and then they did 4 different models where they picked the top 11 predictive variables, and they add just additional clinically important variables. Again, very, very carefully done. They assess the prediction performance of their model based on discrimination, calibration. So very, very, very well designed and very, very carefully done. So to the results, they had, and this is, wait for it, they had 2,089 dogs. So they did mitral valve repair in 2,089 dogs. It's just crazy.
It's amazing.
Two surgeons. Yeah.
What I love is common disease, fine, but such a niche procedure, isn't it? Amongst people in Europe or the US, certainly. And I appreciate there are different population demographics and maybe different expectations in different cultures. So, I think that those numbers are astounding. Absolutely astounding. And for a veterinary study, it's amazing, isn't it?
Exactly. 7 years, 2,089 dogs. The surgery was done by 2 surgeons. Crazy. It's just unbelievable. Again, how inspiring is this program, their open heart surgery program. And now the thing that's also crazy and striking is, imagine the median body weight of these dogs. That's it, the next.
Can I guess? I haven't got the paper in front of me, so
go ahead. What do you think was the median body weight?
I'm going to guess a median body weight of 7 kilos. They're small in the Far East, right?
3.6. 3.6.
I didn't want to go too low.
2.8 to 4.8 kilos. Interquartile range. Unbelievable.
Wow.
They are doing cardiopulmonary bypass in 3-kilo dogs.
75% of their dogs are below 4.5 kilos. That's unbelievable.
It's unbelievable. It's not that only you do surgery in 2,000 dogs, is that they are tiny. They are tiny. Again, very impressive. And that's why I highlighted these papers. Not that it is impressive, the program they have and their success is that what they are trying to do, then they try to collect this data and try to predict mortality and so on. Very interesting. So in terms of mitral valve, the ACVM staging, not very surprising. Majority were stage C, 52%, followed by stage B2. They had 4 B1 dogs, which these dogs are maybe a bit less likely to undergo surgery in the UK, but there were only 4 dogs. Again, the large majority were B2 and Cs. And then just to the results now. So which predictive variables? So the top predictive variables were total bilirubin, total protein, VHS, and LAEO. Those are the 4 most predictive variables. And then there's a lot of different stuff.
Fascinating.
Yeah, it's fascinating. And then again, there were the top 11 variables included stuff like the use of amlodipine, furosemide, drugs pre-op, coagulation times, and so on. But those are the four top variables. And what is also very neat is they create this model, and now the model is available on a web-based risk calculator. They create a web-based risk calculator that you can go, and their final model, you can use their final model. Their final model is available, and just add the requested variables, the top predictive variables, to predict the risk of 30-day mortality, which is very, very neat, very, very neat. And so they just discuss these top variables. Certainly, total bilirubin was a bit a surprise. They were not expected to be one of the top variables, but then they discussed the human literature. Increased bilirubin and hyperbilirubinemia pre and post-op has been associated with increased mortality, and they just discussed that just reflects systemic congestion and very advanced cardiac disease. And there's some papers in dogs out there. There's that paper that says cauda vena cava diameter, and show that cauda vena cava diameter was associated with ACV, mitral valve disease ACVM staging. And there are other studies showing that liver values are increased with advanced mitral valve disease. So it's interesting to see that. Of course, VA vertebral heart score and the LAEO, not a surprise to be top predictors. Well, there will be a lot of more to say, but again, what I think is very, very inspiring is they build this cardiac surgery program. They are doing a large number of surgeries, and now they are proposing models to predict mortality in a really very well-designed study written according to human guidelines on model design. So it's absolutely outstanding. I think it's a great paper.
It is amazing. I think that the one thing to say about it really is that it's that's with these surgeons.
Exactly.
Because they are so experienced.
Yes, exactly.
And they're so amazing at choosing those cases that if we say, oh, well, we can apply this to, I don't know, another surgery team, across the globe, then actually that something different might apply, a different model might apply in those patients.
Yeah, totally. Exactly. Thanks for saying that. That's a clear limitation which the authors have addressed. They say that certainly they do not know if their model can be generalized to other centers, and certainly their experience will play a role, and different models. Maybe this model may not be applicable to other centers. They say that multi-center studies are required now to test the model. Something else also, that because their mortality is so low, then the model overall, the event rate was low, which weakens the model a bit. So they only had 102 cases that experienced death within the first 30 days out of the 2,000 dogs. And so with that is a rather low because they are so good. The low mortality rate affects then the capacity, of course, for the model to how many variables you can have in a model, and you suffer the risk of overfitting and so on because they had 5% mortality. So it's a very low event rate. So yeah, those are the weaknesses. But this is a great first step forward, isn't it, to create these models to predict mortality, and this is the first step then to collect data with other centers across the globe that are doing mitral valve repair and see if the model works and so on. So yeah, very, very interesting stuff.
It's amazing. I was just doing a little calculation here in the background, using their online calculator.
Cool.
Because I think that's quite interesting. So if I've got a 9 kilo cavalier who's on ACE inhibitors, on amlodipine, and if their bilirubin, I'm only going to change the bilirubin. If the bilirubin is 8 mg per deciliter, the 30-day mortality risk is 0. If the bilirubin's 10, the 30-day mortality risk is nearly 9%. So the bilirubin's really important in that model, isn't it? And I mean, I'm just making up some numbers there, but it just goes to show the impact of the parameters which we don't necessarily think of as directly cardiac.
Yeah. The first time that I remember a study to show this that I was surprised was in fact the Hamlet study, right? Because the Hamlet study in their model, it includes ALT, isn't it? And so it's really interesting to realize that other variables, and in this case hepatic variables, liver enzymes, are increased and are associated potentially with ACVM staging and cardiac mortality. And I love that they create the web-based risk calculator.
We can put the link in the episode description for that so that people can go and have a play with it. I think maybe naively, I've often thought about those as just being secondary changes. Okay, there's a bit of hepatic congestion. That'll go away if we fix the mitral valve. But it actually just goes to show that these dogs have got to go through a big physiologic stressor. They go on bypass. They come off the bypass and the cardioplegia. It's a big deal. And it's not just about the plumbing, is it? There's other aspects there. And it's obvious to say that. But instinctively, I've often looked at those changes on some blood work and gone, that's congestion. Is that relevant to the patient? Is it going to change what I do? But maybe it should be changing how we think about them, from a medical management point of view, as you say, based on those results from Hamlet as well.
Agree. And on one hand, it makes sense. It becomes more systemic disease, right? These patients are severely congested and so on, and then they need to undergo GA and the big surgery, as you were saying. What is always really important to remind everyone is that these variables that are picked as predictive variables don't necessarily mean causation. So these variables may in fact are associated with the outcome, but they may be surrogates. And in fact, there might be another variable that is associated with increased bilirubin that is the true cause of death that has not been picked by the model. So the predictors are surrogates of the outcome. So does not always mean causation. So does mean that if we, for example, would address bilirubin, if we would find ways to address bilirubin and decrease bilirubin, this would not necessarily improve the outcome. So I think that's important to remember. But I totally agree with you. We always feel like the heart is the problem, and cardiac dimensions will be the main factor determining outcome, and we just ignore what is happening elsewhere. Cool. So
I thought about Jens Ekstrom's paper on 42 bajillion cats, but actually we talked about that a little bit before, and I wanted to name check it because it's another big sample size paper. But I thought it would be good to talk about a really interesting study from Camilla Pegram and the collaborative team through the RVC and the Vet Compass data, where they have looked at emulating the EPIC trial using primary care-based data. So the title of the paper finishes with causal effects of pimobendan in UK dogs with grade 4 of 6 heart murmurs. So I think this is a really interesting paper because the concept is, okay, we have the EPIC trial, which was published in 2016, and that was a very well characterized group of dogs who were in stage B2 degenerative mitral valve disease, and they were randomized to receive a placebo or pimobendan, and they were monitored to a composite endpoint of death or heart failure. And they looked at the time to that composite endpoint, and I think, as everybody listening will know, treatment with pimobendan in that preclinical phase prolonged the symptom-free period for the dog, improved overall survival, and also was associated with an improved quality of life score. The question is, would we get the same effect if we take that study and we put it in primary care practice? And that's challenging to do for a number of reasons: funding, data validation, etc. But what the VetCompass team have done here is to look retrospectively at electronic health records in dogs who are a suitable size to likely have mitral valve disease, with a suitable murmur to likely have mitral valve disease, and to see if the results of the EPIC trial are repeated in this population or come out similarly in this population. And if they do, it sort of validates that randomized control trial in the real world. This is just a really interesting concept, and I hadn't really considered this before. So the idea is to try and sort of validate prospective randomized trials in a more real world population, which is less controlled. So apparently this is a technique that's been used widely in human epidemiology, and I think this might be the first one in veterinary science. At least it's the first that I've come across. So the study authors had two aims. The first was to emulate the EPIC trial using these electronic health records from UK VetCompass practices. So this is a coding system and allows people to access these anonymized, centralized records. And the second was to see, was the prescription of pimobendan within 6 months of detecting a grade 4 murmur in older small breed dogs associated with a prolonged time to the onset of heart failure signs or cardiac associated death? And did it prolong life overall? So did it prolong the time to all-cause mortality? And the comparison group here is dogs who were not prescribed pimobendan. Instead of the EPIC criteria, where we would diagnose stage B2 based on left atrial size, left ventricular size, their inclusion criteria is a suitably sized, suitably aged dog over 6 years, less than 15 kilo body weight, who has a grade 4 of 6 murmur detected. So they looked at dogs where the murmur was detected between 2016 and 2018. They excluded any dogs with a history of clinical signs that could be attributable to their presumed heart disease, or if they'd had previous cardiovascular drug use. So the potential records that they could be looking at here, so that the total number of dogs in the database was just over 107,000. 6,000 were picked up in the search terms, and almost all of those were reviewed manually by the operators. And ultimately, 928 dogs met the eligibility criteria for this trial. So 178 of the dogs were prescribed pimobendan within 6 months of the murmur being detected. So that's about 19% of the study population. And 750 did not, and that's around about 81% of the study population. So they're looking at a primary endpoint of time to heart failure, or a composite endpoint of heart failure or cardiac associated death. And the secondary endpoint is all-cause mortality. So there's no randomization, but they have therefore to do quite advanced statistics, which is something that I had to Google quite a lot and look up these different statistical methods. This is the life of a cardiologist working in private referral practice. Of course, this population is full of dogs who have lots of other factors which may influence their survival time or their other clinical signs that could be presumed to be cardiac. So it's quite dirty data. And in the statistics, they tried to account for this by sort of forcing different statistical models and putting in things like dogs' age, because older dogs will probably die sooner. The breed, because we all worry that some breeds have more progressive disease than others. The insurance status, that's a really interesting one, because in the UK, in referral practice, we see a high proportion of dogs that are insured, but we're just seeing a very small percent of all the dogs in the country who are owned and not insured and never make it to referral work, and of course, therefore, are managed in primary care. The presence of chronic comorbidities was included. The presence of different practice group was included. So obviously some vets may be more proactive about managing certain things than others, and therefore their patients may survive longer because the vets are very proactive or the owners are very proactive who go to that clinic. And they tried to factor in the presence and use of other diagnostic tests as well. So they tried to use this large pool of data to understand, was pimobendan truly significant in survival and outcome for these dogs, or was it in fact just a byproduct of the animals being insured, therefore the owners could afford pimobendan, and therefore they had other testing and other, better quality diets or more exercise or whatever. So, because of the inclusion period being 2016 to 2018, the authors were able to look at 5-year outcome. Over that 5-year period, in the pimobendan group, 34% of dogs developed heart failure over that whole 5-year period. And in the dogs not given pimobendan, the proportion with heart failure was higher. It was just over 56%. So the use of pimobendan reduced the risk of heart failure and also prolonged the time to the onset of heart failure signs by 311 days. Now, anyone who knows the EPIC trial will know that in the EPIC trial, it was over 460 days was the difference between the groups. Now, of course, this is a different population of dogs, so we can expect the numbers to be different. And this is a bit more of a sort of validation of that benefit of pimobendan that was reported by the EPIC authors. So 311 days, it's almost a year. It's pretty good in terms of tangible longevity and benefit to the patient. So we're not finding hugely different results here, but probably the difference can be explained by just being a different population of dogs. The secondary outcome, all-cause mortality, there was also a difference in that. So there's a 10% difference between groups, and the numbers over that 5 years, 19.8% of the dogs on pimobendan were alive at the end of 5 years, and 9.6% were alive without the pimobendan. So the pimobendan appeared to prolong time to the onset of heart failure and improve survival in this population of dogs managed in primary care practice. So the authors report that this does seem to validate the results of the EPIC trial. Now, I think we would expect that. The statistical differences in EPIC was so huge, the benefit of pimobendan was so obvious in that population. The trial was actually aborted early because the benefit was so great at an interim analysis. Now, obviously, in primary care practice, murmur grading is important here because the vet has to grade this as a grade 4 murmur. And some days I might grade something as a grade 4 and I might grade it as grade 3 the next day. It's very subjective. So, of course, there's a little bit of fluffiness of including the data there, and a bit of inaccuracy could be introduced. And we don't know that mitral valve disease was the cause of the murmur. However, it does feel more likely if these were adult onset murmurs in dogs over 6 years of age, left apically located, and in smaller breed dogs. So I think it's a really interesting study. I think there's some real strengths. Number one is that it sort of looks at this technique of retrospective validation of a randomized clinical trial in a less rigorously controlled population of dogs in a more generalizable setting to the average vet practice. So I think that's quite cool as a sort of academic exercise. And the data set here is what we always want to see to understand global benefit. We want to see data from primary care practice. It's just really hard to get the trials in primary care practice that meet the sort of tight criteria for good clinical studies. The limitations, I think, maybe there's some misclassification of results here. And we don't know that these dogs had stage B2, do we? Maybe they were a B1 with a loud murmur. It's hard to say that we were a very tightly controlled population of dogs. So there's a lot of confounding variables here that are impossible to control for. But I think it's really, really interesting to try this technique. What do you think about it? I'd love to know your perspectives on it.
I agree. I think there's a lot of exciting stuff here. I'm always so impressed with the Vet Compass database. It's so neat that they can use data collected in primary care setting, and the way the database is organized and so on is just brilliant, absolutely brilliant. And I've been always a bit how shall I say, not sure if sad, but I was always hoping that, because there are so many studies using the Vet Compass data, but there was nothing in cardiology, right? I don't think there are many studies out there looking at with cardiology data. It's very exciting that the Vet Compass team has now also start looking at some cardiology data, and I agree. And then, well, great that the Vet Compass data allows them to do that, and that this target trial emulation is really an interesting concept that I've never heard before. And I think it's really important is exactly what you said. To be part of a clinical trial, clinical trials are not real world patients, because the inclusion criteria are so tight that to be part of clinical trial, you need, of course, to tick so many boxes to satisfy all the inclusion criteria and the exclusion criteria, that they do not really reflect real life. And that's why there's also a very common type of trial called a pragmatic trial in humans, where people are just given the treatment drug or potentially placebo, or are not treated, but the inclusion are less strict. So it's really great to see that, okay, maybe you start with a randomized clinical trial and then you test that drug in a real world situation with pragmatic clinical trials or a target trial emulation, as they did here. So very exciting time. I think it's really cool that they did that. And hopefully this will help many dogs. As you said, they will not be able to, not all dogs will be classified correctly just based on heart murmur grade, because grading heart murmurs is challenging, and because not all B2 dogs will have grade 4 and vice versa. But if the clinicians use the criteria, other criteria, such as the Hamlet study has suggested, and they look at the patient signalement and so on, they will narrow it down and hopefully make mitral valve disease in stage B2 way more likely. So it's good to see this, because certainly not all dogs can afford and will see a cardiologist. And so if some of these dogs can still be treated and properly treated, I think that's great news.
So do you think there's a danger here of, I'm playing devil's advocate now, I should say. Do you think there's a danger here of primary care vets seeing this and saying, we just don't need to echo these dogs anymore. We don't need to take any radiographs. We don't need to assess heart size, because it's a grade 4 murmur.
I think it's really important to remember that most dogs with mitral valve disease will never develop stage C, will never progress to congestive heart failure. And so, because I think what one could think is, okay, every dog with a murmur would just be started on pimobendan. So I think it's important to first remember that the majority of dogs will never develop stage C, will never develop congestive heart failure. So many dogs will remain asymptomatic forever. And so, or they will die with the disease and not of the disease. And so it's certainly only dogs that have a loud murmur. Now, if you put together a loud murmur, the right breed and the right age, I think it will make it very likely to be mitral valve disease. I think the vets should still suggest echo, because that's the gold standard to guarantee that the dog indeed because there are dogs with grade 4 murmurs that may have musical murmurs, for example, and mild degrees of mitral valve disease. Certainly not every dog with a grade 4 will be in stage B2. So I think ideally, certainly dogs should still undergo some form of imaging. So I think it's still important the clinician is a critical thinker and will not just start pimobendan in every dog that has a loud murmur.
Yeah, I mean, I completely agree. The point of this study, from the author's perspective, I think, is not to say don't do the imaging. What it's doing is saying, can we validate the results of the EPIC trial in a more open, generalizable population of dogs who are not being managed by specialists and who probably have more comorbidities and issues with finances and everything else, these real world things. The authors are not saying, let's forget about imaging the heart and let's just treat these dogs, because we don't know how many of these dogs had stage B2 and therefore were in the higher risk category for further progression, clinical signs, etc., at the start of the trial. Maybe some of these dogs were treated for 2 years on pimobendan before they really, in inverted commas, needed the drug. So before we would have classified them as needing the drug based on their imaging findings. And if you look at the costing of that, certainly in the UK, based on average practices, and I've had a few conversations with friends confidentially about their pricing structure and pimobendan and dispensing fees and things. And actually, you can break even on seeing a cardiologist once a year or twice a year even, versus giving pimobendan to a 10-kilo cavalier. So what I mean by that is you might spend £1,000 in a year on pimobendan for a dog, and you can probably see a cardiologist once or twice, depending on your local pricing structure, for that. And at least if you see a cardiologist, you're treating the right thing. The dog needs the treatment. If we forget about referral to a cardiologist and we talk about taking some chest x-rays in practice, or combining that with a sort of focused echo, if people have had some training and can fairly reliably measure a left atrial size and a left ventricular internal diameter, then actually you'll save money by imaging in those dogs who don't need it. And if you image and you find that dog is definitely a stage B2, then we'll start treatment and we'll be confident that we're treating the right thing and we know we're doing the right thing for that patient. I've talked about this before on this podcast, and anyone who's seen me give CPD knows that I bang on about it quite a lot. But if we have an animal on long-term medication, it changes how we act. It changes the owner's relationship with them. It changes our advice to the owner as a vet. And that can negatively impact the welfare, particularly in those patients who do not need the drug. And the example I always use is, shall we do some dental work to improve the dog's day-to-day quality of life and well-being? And the dog's on pimobendan and the owner says, oh no, he's got a bad heart. Now, how often do people look back through every page of the notes to find out that he definitely does have a bad heart? If he's been on pimobendan for 6 months or 12 months, you might just go, oh yeah, our so-and-so put him on this drug and therefore he must have a bad heart. And they don't anesthetize him, don't deal with the periodontal disease. And actually, that's a big day-to-day quality of life issue. And if that dog never has cardiomegaly, then maybe we're spending a load of money on pimobendan that we don't need to spend. And more importantly, that dog's suffering because of decisions that we've made or not made for that patient. And nothing's done with any malice. It's all done in the best interests of the patient, of the owner. But I think this empirical treatment or blind treatment can get in the way of helping our patients. And I think that's particularly important in a primary care setting.
And yeah, exactly. And important to say that several of these dogs had an imaging test or diagnostic test performed. That's important to say. So 40% had echo, 19 had NT-proBNP, 8% had radiography. So it was not that the vets just auscultate a murmur and said, okay, this is a stage B2 dogs. They put together different pieces. And again, 43% had an echo. And there were cases with BNP and that had the NT-proBNP done and thoracic radiographs. And so vets had also this information to determine if dogs were likely to be B2 or no. And if you look at one of their table, 96% of dogs on pimobendan had a diagnostic test performed. So it's not just based on the murmur. The vets had other information. I think that's certainly the right way to do it. Vet will put together.
Yeah.
So to answer your question, I don't think we should just grab the stethoscope and say there's a murmur, let's start pimobendan, because the vets in this study, the vets that treated these dogs, had done either echoes, X-rays, or NT-proBNP to help with their decision making.
I just hope with trials like this that people take the results of the trial in the spirit they were intended. And I think if you read the paper, you would take that. But I think if you skim read the abstract, maybe you wouldn't take that, and maybe people will go, oh, this means we can just treat them. I don't know. Maybe I'm just skeptical.
Yeah. Very cool. So shall we move forward to other more exciting diseases than mitral valve disease?
I can see the direction we're heading in. So moving away from mitral valve disease and towards cardiomyopathy. Now, people are predicting that we're going to talk about feline cardiomyopathy, but actually, in the lead up to this episode, we were both going to choose the same paper on human hypertrophic cardiomyopathy to present. So actually, I've won the reward of discussing the paper, but there's a lot of data coming out of this trial, isn't there, that we can talk about? Yeah. So we can both chat about those other analyses. And the paper that we wanted to talk about, a paper in the New England Journal of Medicine called Mavacamten in Symptomatic Non-Obstructive Hypertrophic Cardiomyopathy. And this trial is called the Odyssey HCM trial, or the Odyssey HCM investigators are the authors. So mavacamten, now that's something that any regular listeners will have heard us talk about with Josh Stern and briefly with David Connolly at ECVAM a couple of years back. So this is a drug that has been real interesting in cats. And actually the data out of the Stern lab looking at the effects of aficamten, mavacamten in feline cardiomyopathy models showed that the myosin inhibitors, the small molecule inhibitors, were able to reduce left ventricular outflow tract obstruction in cats with obstructive HCM. Now, for the drug developers, for the pharmaceutical companies who own these drugs right now, that's a big finding, because in humans, left ventricular outflow tract obstruction is a massive contributor to progression, to mortality, to impacting quality of life negatively in people diagnosed with HCM. So this is something that's already in use in people with hypertrophic cardiomyopathy who have got an obstructive gradient, because we know it reduces their symptoms. An interesting question is, does it have any benefit to those patients who are symptomatic for their HCM but do not have obstruction? Because that's a really important question. Not all of these patients with HCM are obstructed. It varies how common obstruction is in people, but on provocation, I think it's fewer than in the population of cats we see with HCM, because one of the reasons we see cats with HCM is murmur investigation. And in humans, clinical signs or symptoms that the patient feels may be more likely to be what takes them to the doctor. So in this study, a total of 580 adults with symptomatic but non-obstructive HCM were enrolled over an 18-month period, and they were randomized to receive either mavacamten or a placebo drug. So the duration of the trial was just under 1 year, and these people had to have a left ventricular outflow tract gradient less than 30 millimeters of mercury at rest, or less than 50 on provocation. They had to have some symptoms of disease, and they had to have a normal ejection fraction on their echo, so greater than 60% on their echo. Their NT-proBNP levels were supposed to be elevated to gain entry into the trial, and also they had to have limitation of their activity. So that was done, the assessment of activity was done using something that I hadn't come across before, but sounds like a very commonly used method in humans, which is called the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score, which is super catchy. And it's a patient-reported measure of symptoms and physical function. So the endpoints of this trial, mavacamten versus placebo, were a change in their peak oxygen uptake. So this is cardiovascular fitness at its most experimental, but also most objective. So this is measuring the VO2 max of the people, and it's measured between the baseline and week 48 on exercise testing in a very standardized manner. This is something we can't do in cats with cardiomyopathy, but good luck if you want to put a cat on a bike wearing a mask. The second factor they were looking at was a change in this clinical summary score of physical function. I was reading this thinking, I bet there's a big difference, a big benefit to these patients. You can see from the population data, the mean age is 56 years old. The majority of them are male, but there's also about 46% of people who are female in this study, so it wasn't a huge male bias. And at baseline, they had their VO2 max and their clinical summary score measured. Over time, there was very little difference in the increase in the VO2 max. There was an increase in both groups. It was smaller in the placebo group than in the mavacamten group, but it didn't reach statistical significance. So the p-value on the VO2 max difference was 0.07. You could argue there's a trend towards significance there, but it didn't reach statistical significance in this population of 580 people. So even if there is a difference, is it enough for us to think about using this drug as a priority in this group of patients at a population level? I'm not sure it is. Thinking about the clinical quality score, so the symptoms of these people, there was an improvement in both groups against the mavacamten versus placebo, and the p-value of difference was 0.06. So again, a trend towards significance, but you could argue that not enough significance to make a difference on a population level. So there were some changes to NT-proBNP and the symptom scores over time. There were some improvements, but they weren't statistically significant. And they did do subgroup analyses, because with these larger populations in people, they tend to do some subgroup analyses to see is there any difference for a proportion of the population. That didn't reveal any clear benefit from the use of mavacamten versus placebo. What was interesting is looking at the safety, because we would presume a placebo drug would be safe, but actually the mavacamten here, they put into place some checks and balances, because we know that mavacamten reduces systolic function. It inhibits myosin, and therefore if people's ejection fraction reduced below 50% in this population, so remember they were all starting above 60%, and if it reduced below 50%, they had either temporary, or if this was a sustained reduction in ejection fraction, they had permanent discontinuation of. And actually, 1 in 4 people on the mavacamten had interruptions to their drug therapy because of a negative effect on ejection fraction. And 1 in 10 people was removed completely from the trial from the mavacamten group. So these are adverse events that relate to systolic dysfunction associated with the drug use. Now that's interesting. So again, it does suggest that, should we be giving these drugs to every person that's affected by HCM? Well, maybe the risk is greater than the benefit in this population. This was looking at the clinical outcomes, and there was no significant difference between the groups over a 48-week period. So the authors say it's not enough to support using mavacamten in non-obstructive HCM because of that balance of risk versus benefit. Now, as the cardiomyopathy guy, what are your thoughts and what are your insights into the other parts of this Odyssey HCM investigation?
Yeah, I think this is all very exciting. And just cardiac myosin inhibitors, both mavacamten and aficamten, have shown to be very beneficial in patients with obstructive hypertrophic cardiomyopathy. As you mentioned, has improved quality of life, reduced symptom burden, improved their VO2 max, has shown to have favorable effects on short-term and long-term cardiac remodeling, has decreased the indication for septal reduction therapy, which is a really big thing as our listeners will know, septal reduction therapy is the first line approach for patients that do not respond to medical therapy. And we are talking about septomiectomy or alcohol septal ablation. So mavacamten and aficamten have been shown, cardiac myosin inhibitors have been shown to reduce the indication for septal reduction therapy, meaning people that start on these drugs may not require surgery.
And that's amazing. If you can avoid surgery, right?
Yeah, exactly.
Huge benefit. Yeah,
that's huge. So there's a clear benefit of the obstructive HCM. And now I think everyone was very exciting to see what happens with non-obstructive HCM. And as you just said, in this clinical trial, there was no the clinical trial was negative. There was the drug was not statistically different from the placebo on the primary outcomes, which I think is really cool because it truly suggests that these two forms of HCM are two different diseases. They have completely two different behaviors, which is really cool.
Yeah.
The obstructive form and the non-obstructive HCM, they are different. They are really different. They are two different diseases. And even though they may have the same sarcomeric mutations, and they are caused by the same sarcomeric mutation, they have different natural histories. They have different pathophysiologies, which is really, really, really interesting. And
there's
so
different forces on the ventricle, aren't there? There's different modifications to the, if the gene is the substrate, then you've got the triggers and the modifiers on top of that. And I think that's super interesting.
Exactly. So it's really exciting. It just proves that there are two different forms of the same disease, and they respond to medical treatment potentially differently. And it's really interesting always to realize that there's no approved medical therapy for non-obstructive HCM in people. There are no good drugs out there for non-obstructive HCM. So I think sometimes we are a bit frustrated in cats that we don't have medical treatments to treat HCM yet. Hopefully that will change very soon, or is changing. But the same is true for non-obstructive HCM in people. So I think it's really interesting to realize that. And then and also we may discuss this maybe later on, is to see how can we what this data can tell us about how we may treat our cats with cardiac myosin inhibitors. Maybe we discuss that later on. But as you were saying, then what the authors did, so the clinical trial was negative for the primary endpoint. So there was no improvement in exercise capacity or symptoms. But the secondary endpoint, when they looked at NT-proBNP, cardiac troponin I, and echo variables, there was a marked difference between placebo and mavacamten. So there was a 58%. Yeah, that's really interesting. And the graphs are striking. So there's a 58% decrease in NT-proBNP and a 51% decrease in cardiac troponin I. And there was decrease in left ventricular mass, decrease in wall thickness. I think it's easier for us to think about wall thickness. There was a mean difference of 2.1 millimeters, 2 millimeters difference. Also moderate improvement in diastolic function, E to E prime, left atrial function strain improved in the patients on mavacamten. So this is really interesting. So there were changes. The patients on cardiac myosin inhibitors had some evidence of reverse remodeling, potentially some evidence of decreased filling pressures and myocardial damage. But these did not impact or reflect into clinical improvement, exercise capacity, symptoms.
Not over the 48 weeks, though.
Exactly.
It's a short period of time.
Yeah. That's exactly now the open questions. Yeah.
We're talking about a disease here which has a decades-long history and progression in the majority of people. So therefore, what does less than 1 year mean in terms of outcomes? Maybe we should be looking at 5-year or 10-year outcomes rather than 48 weeks.
Yeah, exactly. And that's what the authors hypothesized. So really important to say that I would encourage everyone to read the editorial for these sub-analyses. So as Kieran said, the Odyssey trial was published in the New England Journal of Medicine. And then these two sub-analyses, so they looked at change in echocardiographic variables and biomarkers, were published in JACC, in the Journal of American College of Cardiology. And that was an editorial was written regarding these two sub-analyses. And they are so also the authors were very careful with their sub-analysis and their conclusions. And so it was the editorial. They really stress that sub-analysis of a clinical trial are by design exploratory. They do not revert or prompt reinterpretation of the main results of the trial. The trial was negative, and no one is discussing that. The trial was negative. Now they are looking at these sub-analyses, and these are hypothesis generating. These are hints for future clinical trials. So what they've showed is there are signs of cardiac remodeling, positive cardiac remodeling, and change on the biomarkers that should be pursued and understand why did this happen in the cardiac myosin inhibitors. And as you were saying, group, is it because they did not have enough? Do we need more time on these drugs? Should the drugs be started earlier at the disease, and then to give it time for this potential beneficial effect? So it's really exciting that, okay, the main trial was negative and that's it, that's okay. And now they are looking at, but in this sub-analysis there were differences. They are not saying that because there are change on echo or change on biomarkers that people should be start on mavacamten with non-obstructive HCM. All they are saying is there is a sign here, there is something here that now they will pursue and understand what is going on, because there was change on the biomarkers and on echo, and it's really nice to see how they write and how careful they are with their sub-analysis. And I think this is really interesting, because this in one hand mirrors what happened with the delay study, if you want, where the delay study, the primary, so the delay study where spironolactone and benazepril was tested against placebo to see if these drugs would delay the onset of congestive heart failure in mitral valve disease dogs. The primary outcome was negative, so this combination of drugs did not delay the onset of congestive heart failure. But then when the authors look at echo variables and biomarker variables, there was a change over time on those variables in the treatment group. And again, this just raises hypotheses. It's not saying that the trial now is positive, just raises hypotheses. It's something interesting to chase and understand why is that happening. So yeah, overall, I think is very exciting. And there's another study going on now, so the Acacia study, where they are looking at aficamten in non-obstructive HCM. So mavacamten was the first in class, the first cardiac myosin inhibitor. Aficamten was the second in class, which has also been shown to be useful in obstructive HCM. And there's an ongoing trial now looking at non-obstructive HCM. So it'll be interesting to see if aficamten, the results will be similar to the Odyssey study or no. And it's really exciting stuff. Really, I'm really looking forward to see what's happening when they start looking at these echo variables and biomarkers and so on, to see if indeed these patients just need more time on this drug or no, or if maybe the drug doesn't work at all on these cohort of patients. But very, very interesting. Yeah, very interesting.
I think that the whole field of novel therapeutic agents for HCM is unbelievably exciting and could be a game changer for us. In Europe, I feel like we're almost being left behind, and I understand why, but it's from a regulatory perspective, we don't have access to Felicin CA1, the sirolimus, which has been provisionally approved by the FDA in the US. And there are owners of cats that I have who are desperate to get hold of this drug and desperate for me to prescribe it. And they're coming up with these websites where they can get, something from Dr. Bob or whoever online. And he says he'll prescribe the drug for them. Now, that's illegal under our CVS guidance. He can't. Dr. Bob in the US cannot prescribe for an animal he's not physically examined. In the UK, that's breaking the law. And we can't import this via the legal routes in the UK. We can't get hold of Felicin CA1. So therefore, owners are reaching for these other options and formulations of the drug that are not safety tested, that are not efficacy tested. So I worry about that. And also things like the Camptons. I know colleagues in Malaysia and the Far East who are using these drugs. they have access to these drugs for cats. So I've been asked by colleagues over there for advice on how to use them and dose. I said, I don't know. I can't. Not all the people in the UK who need it, who would benefit from it, can get hold of it. So we can't get hold of it for cats. So of course, across the globe, there are listeners who are going to be in a very different set of circumstances to us and have different drugs available. And I think it's kind of amazing in one way because of all this opportunity, but it's also a bit like the Wild West. We have access to these drugs. We're not really sure on what the long-term effects of them are. Even rapamycin, sirolimus, we're waiting for the results of the HALT-HCM trial to understand, is there a benefit in long-term use of rapamycin in cats with preclinical cardiomyopathy? Doesn't mean I wouldn't like to try it, and I wouldn't like to help those owners who really would like to do everything they can to try things for their cats with progressive preclinical HCM. But we're in a position where we can't get hold of any of that in the UK. I'm just rambling now. What are your thoughts on it? It's an interesting time.
I agree. It's an interesting time because indeed we don't have access yet to rapamycin, as you said, in Europe. So it's kind of an interesting time. Looking at this Odyssey clinical trial and Acacia in the future, what I think is really exciting is for us to understand, would cardiac myosin inhibitors have a place in treating cats? And again, we don't know what's the percentage of truly obstructive cats, right? We don't know how cats have truly severe obstruction or what it means. So most of our cats might be within the group of non-obstructive HCM. So to me, this data, this human data, is very exciting. But I think this could guide us and could give us hints of what would be the future of cardiac myosin inhibitors in cats. Because maybe our non-obstructive population is bigger than the obstructive population, potential obstructive form. So in humans, the non-obstructive form is something between 30 to 50%. So the majority have obstruction, which might be different in cats, or at least severe obstruction might be less prevalent. I don't know. But so that's why I think this data is so exciting to understand which cats to treat. If we have even if we have cardiac myosin inhibitors, which cats to treat? Because right now the non-obstructive form in humans, there doesn't seem to be an indication for patients with non-obstructive HCM. So I think this is really a space to watch for us veterinarian cardiologists and clinicians to understand what happens in non-obstructive HCM. Because this might be might mirror a bit better what we see in cats. So cats that go into congestive heart failure due to severe diastolic dysfunction with very high filling pressure that are not obstructive. This is probably most cats we see with in stage C. And so I'm really excited to wait and see what is happening with cardiac myosin inhibitor non-obstructive form HCM in humans, because I think this will be the population. These results might be useful for us in the future in cats, because I agree right now I would not know which cats I would treat with cardiac myosin inhibitors.
And the first step for us is to decide what obstruction is. Is it 30? Is it 50? What does that mean? I mean, for me, I think 50, 30, I'm interested. 50, I'd call it obstructed. But there's no consensus on that, right? And everyone's doing different things. Some people will see systolic anterior motion, they'll see aliasing on the color, and they'll say, oh yeah, this cat's got obstruction, but they don't measure it.
Yeah. And it's, again, as we discussed so many times, is labile and change over time. And they were so careful. It's also interesting to read the materials and methods of this clinical trial, because they were so careful to guarantee that these patients were truly non-obstructive. They did all the Valsalva maneuvers and so on to be sure that these patients were non-obstructive. And that's challenging in cats. I agree. It's challenging to define which cats are truly obstructive. That's why, again, this data is so important for us, I think, in the future, because then if cardiac myosin inhibitors are useful in humans or in certain cohorts of humans with non-obstructive HCM, this might be also true in cats. We just need to wait and see what they find. We need more data on non-obstructive HCM in humans to then try to understand what might be the future in cats, I would think. I think this is exciting for rapamycin, because hopefully ramp up, because again, the first pilot study from Dr. Stern, from Joshua Stern, was on non-obstructive cats. So they excluded cats with severe obstruction. And so in fact, rampamycin in the first pilot study was on non-obstructive HCM. And so it would be brilliant if rampamycin truly has an effect on HCM and non-obstructive HCM potentially, or both forms. That would be very exciting, especially if cardiac myosin inhibitors are not an option anymore. Potentially, this would even make rampamycin a better option, or a more exciting option.
Interesting times. Well, I look forward to your forthcoming study with 580 cats with well-characterized obstructive HCM, and we can see what the outcome there is. That would be fantastic.
Yeah, you should invite me to your podcast, and I'll come and
when you moved on, and I'm just doing it by myself, talking to myself about papers, I'll invite you back as a guest. Yeah.
That's very kind.
Very
it's a great
good.
pleasure to be here. Great. So, this was, I don't know, I hope the listeners will enjoy. I really like to discuss these papers. Was interesting. And I've
not even talked about pulmonic stenosis once.
That's I was convinced you would pick a congenital heart disease paper.
Well, next time we can do another one in the future. Maybe no one will listen to this one, but perhaps if people do listen and express it's interesting, then we will pick some other stuff in the future.
Yeah, it would be great to have your feedback on today's podcast. Just drop us an email at animalheartbeat@gmail.com, or you can just message the hosts.
Thanks everybody for listening.
Great stuff.
Jose, thank you. It's been emotional as always.
Thank you. All the best.
Yeah, take care. Bye-bye.
Thank you. Bye-bye. You have been listening to the Animal Heartbeat. Thanks very much for our listeners.
Keep in touch by finding us on social media or sending us an email on animalheartbeat@gmail.com. Please remember to like, follow, and share to help us find new listeners. And make sure to check out our previous episodes wherever you get your podcasts from, or on our YouTube channel.